Welcome, everyone. Thanks for joining us today. I think I know everyone who is on the call. Um, do we all know each other, or should we shortly introduce each other? Because we are a small community, so it would be nice if everyone knows each other. Well, so I get started. I'm Anja Roden, thoracic pathologist, surgical pathologist from Mayo Clinic in Rochester. Greg?
Greg Fishbein, cardiac and pulmonary pathologist from University of California, Los Angeles.
Thank you. Carmela?
Hello. Hi, everybody.
Do you just want to quickly introduce yourself, please?
Yeah, Carmela Tan. I'm at the Cleveland Clinic doing cardiovascular pathology.
Thank you. Nahir?
Yes, I'm Nair. I am a pediatric pathologist at Texas Children's Hospital with interest in cardiac and lung pathology.
Very nice. Alex?
Hi, everyone. I'm Alex Wein. I'm at WashU in St. Louis. I just finished residency a month-ish ago and now in the lab, interested in lung pathology.
Very good. Katharina? Oh, Katharina seems out. Okay. Francesca?
Hi to everyone. I'm Francesca Lunardi. I'm a molecular biologist and a thoracic pathologist, mainly involved in lung transplantation. And nice to see you all at the University of Padua, sorry.
Fantastic. Elizabeth?
Elizabeth Pavlisco, thoracic and cardiovascular pathology, Duke Hospital, Durham, North Carolina.
Thank you. Chi-Yu?
Hi, I'm Jiu. I'm WashU in St. Louis with Alex, and then I do cardiothoracic pathology.
Great. Martin?
Yeah, I'm cardiothoracic pathologist at Royal Papworth, and I'm currently treasurer of the society and hence part of the executive committee. So I have a sort of dual role.
Great to have you. Catherine?
I'm at Cincinnati Children's and I'm a lung pathologist here. I do both pediatric and adult lung pathology, mostly pediatric right now. And
Thank
then
you.
Plant here.
Great. And Jerry?
Jerry Berry from Stanford. I do heart and lung.
Perfect. Thank you. So I think I got everyone.
I just managed to unmute myself. I'm sorry. I'm Katarina. I'm currently on holiday and I'm on the but I'm a cardiothoracic pathologist, both working heart and lung and both adult and pediatric. And Juliet, may I ask you to mute myself again? I'm sorry.
And Juliet?
I am Juliet Osazamide. I am the Governance and Communities Administrator for ISHLT.
Perfect. Thank you. So thanks again, everyone, for joining. It's a great group. We have a few things we wanted to talk about. And before we dive into any of the discussions, I just wanted to give a few updates. One is just to inform you which proposals we sent for the Standard and Guidelines Committee for just for a first look, and then they will actually decide which of the guidelines should be developed or rewritten or updated and so on. So one was the guidelines for processing explanted native and allograft lungs. One was the guidelines for processing explanted native and allograft hearts. And for the update, there was the 1996 working formulation for the standardization of nomenclature in the diagnosis of lung rejection, which was revised in 2007. So we are still waiting for officially to hear back about any of these guidelines, which we would be able to revise or actually establish. However, in the meantime, before we have the last word from the Standards and Guidelines Committee, I would like you to think about which role you would like to play actually in developing these guidelines or revising the guidelines, right? So someone it would be great if someone would take the lead on these guidelines, and also for the potential update of the revision of the nomenclature for the lung rejection. Any questions for those?
Hey, Andrea, do we know when we're going to hear back from them? Like, are we talking about like, we'll hear back, soon, or like in the next annual meetings, or do you know?
No. Sooner. Yeah, great question. So hopefully, actually, within the next couple of weeks, it looked very promising for the guidelines for the explanted native and allograft hearts, and for the revision of the nomenclature. It didn't look so good for the explants of the lungs, but we did discuss that, and so hopefully we will get that granted as well. Yeah, but sooner rather than later, because specifically for the explants, I think these are guidelines which are very much needed and should be actually developed in the very near future.
So
Any
Anya,
other? Yeah.
can you like give us some insights on the timeline that is given by ISHLT? Like how long before you actually, come up with a final recommendations or guideline or
That's
processes?
Great question, Carmela. And I don't know exactly how the turnaround is. I mean, part of that depends on us, how fast we will develop the guidelines. But I don't know for how long it will take for the Standard and Guidelines Committee. But maybe Martin and Juliet, you could give us some insight, please?
Yes, go ahead, Martin.
So yeah, standards and guidelines will advise you on a timeline to do that, and if it's approved all the way through, you'll get staff support on that. But there will be increasing pressure for you to deliver on that timeline, and the person in charge will be accountable through their ISDN to the Standards and Guidelines Committee for ensuring that they are delivered within a time frame. We've seen too many go off course and take years to develop. So there is now a much more stricter process and oversight of this, and earlier intervention when we think things are just drifting. And that's not pointing a finger at pathologists. That is across the society we've seen this issue. So, it will be an agreed time frame that will then be expected to adhere to. So that's kind of where it is. Juliet, have you got anything further on that?
No, that's pretty much it.
Yeah, and as far as, support, what does the society offer? Because sometimes you need to, I know a lot of things can be done by, through Zoom meetings these days, but sometimes you also probably need like an in-person that can happen during the meeting. Is that still the usual practice, or everything is just done through Zoom meetings and back and forth emails?
Again, that's kind of down to you. I'm sure a breakout room of some sort, provided we have sufficient notice of it, can be provided. I mean, particularly for a small group like this, within the context of the meeting, I think I would strongly recommend that that's certainly a way of kickstarting it, getting things allocated, making sure things are on track and everybody knows what's going on. But space is short within the conference centre, and identifying that resource is an important one. Really, the resources offered is staff time to help coordinate those Zoom meetings, and Juliet and colleagues are outstanding at that. But they have as you will understand, they have an awful lot of meetings to coordinate for all the groups on hand. So but that's really what we can help with.
We are carving some time for PCs and IDNs to meet. The actual location, it's still to be determined, but there will be some time for each PC to meet up in person at the annual meeting.
Well, I guess the hope would be that we would be able to start sooner than the annual meeting, I would say, because that's, over half a year away.
Yeah, I think there's a lot of work, or preparatory work can be done beforehand in many ways. Then the time you are together is much more valuable. I certainly know that when Jerry was organising some of the antibody-mediated stuff, homework done before paid dividends in then having the interface meetings further down the line.
Yeah, I would just add that maybe I'm being overly optimistic, but it seemed to me that because these are very much like a professional community project and is not really something that's going to fall on the shoulders of people outside of our team, it's kind of a no-brainer that they're going to get approved. I think the issue with lung, at least maybe I got the impression wrong, was more of like it fell off the radar rather than was meeting some opposition. I don't think anybody is going to oppose us doing these, and I think they need to be done regardless of where they're, what the affiliation is. So I would suggest that we don't wait for any sort of a approval to even start thinking about who wants to become involved, and that's my take.
No, I think that's perfectly reasonable. But presumably these have been through your ISDNs for cardiac and respiratory.
Well, I think it
right.
definitely went to the cardiac, but it seemed like it sort of fell off the Word document and maybe was not discussed in the pulmonary. But we spoke with Greg Schultz yesterday, and he assured us that it wouldn't be an issue, getting this back on the radar.
It shouldn't be, strictly speaking, within our processes. And, even though you're a community and it's a within community project, having the oversight, well, at least the sort of sign off at the ISDN level, because that fits within the interdisciplinary network level, that fits in with how we expect everyone else to sort of work and function, even though the project is owned purely by a community.
Right. So as I said, we discussed it in our in the cardiac IDN, and people were very supportive. They gave it a high priority, and said that they were surprised that we didn't already have a document like that. And so I think there's no reason why high priority things from two different communities can go on at the same time. So I don't see why anyone would say you can't start doing this now.
No, I think the Standards and Guidelines Committee Standards and Guidelines will want to know that the community has the capacity to deliver everything it wants to deliver. And if you need to stagger this in some way, just because you can't do everything at once, then within a small community, I don't have a problem with that. But that's really for you as the leaders to sort out.
Yeah, completely agree with that. Well, thanks everyone. I like the idea to actually get started thinking about it. So if one of you would consider taking the lead on any of these projects, please let us know. Keep it a thought, because even though it seems like straightforward, it will be a bit of work, and will be also some work of coordination of the other people who will work on the project with you. And so, yeah, please let us know. Any other questions to that? Okay, then the other update is on the elections. So we don't really know who nominated themselves for any of the positions in the leadership of the pathology community. There were 4 positions open. We probably will receive the names in the near future, but for everyone, the elections are in September. So please keep an eye out, probably by email, and please select your people. Then the others is, as I put in the agenda, don't forget about the abstract for the ISHLT annual meeting. It's in October on the 17th, and please consider send in some abstracts. It was actually a great teamwork for the symposia. I really liked seeing what was done. Quite a few symposia proposals were sent out, and so now we'll see, hopefully some of them get accepted. Yeah, now let's get into the discussions. The first discussion point would be ideas for research projects where we all could actually come together and join the efforts and join our cases and our ideas for research projects. So please, whoever would like to take the floor.
I'll just throw in one of the things actually I mentioned in the last ICHT pathology town hall meeting. that Alex is my trainee, awesome trainee, and then we actually putting in a SHOT abstract looking at the vascular change in the mostly lung explant with a subset of ongoing cases. Is that we are forming a observation / case series is that in addition to the traditional like chronic like D1 vasculopathy changes, in the past few years, we start to identify initially, we always say in the report, say, clinical significance unknown of the larger vessel with either transmural or at least focal inflammations in the larger arterial or muscular arteries. So we pull off all of our data at WashU, both from the explant lung and the biopsy. So we will submit the abstract to this year's ICHOT, and we did some preliminary study with just basic scan and showing that this might sound a little bit catchy, but basically we think that there is a lesion that is kind of mimicking what we see in the heart transplant, which is almost like QT, and then also similar to the bolt that you see in the lung transplant, is that those inflammation is actually reactive rather than true vasculitis. Our preliminary data show that it's a mixed B than T cells, and actually in some of the cases are more B than T cells. And then the clinical follow-up of the cases, some of the patients keep having this lesion, but never develop real, clinically meaningful rejections. We're also going through back to our older lung autopsies, but those tissue are, just because the intrinsic limitation of autopsies is harder. So that's something I actually mentioned in the last town hall that I would love to collaborate with people and then to get more cases to really dive in and to characterize the vascular change. And Julie says there's some funding. And then because for instance, in our center we only identify about like 30, 40 lung retransplant because that's fairly rare compared to the heart retransplant. So and then as we plan to do further studies out and to characterize those immune cells. And then but as of now we do think that they are a wider range of vascular change in lung transplantation, not just the D1, like the the neoantigen formations, the vasculopathy. And that's a project I would love to have anyone's input in and to expand the cohort. Andrea, you are muted.
Sorry. So that sounds really interesting to me, and I know we discussed that. And I'm just wondering, how often do you see inflammation in the pulmonary artery? I assume when you talk about explants, you talk about the explants for retransplantation.
For retransplant,
right?
so that's not that much. Yeah, it's not.
Yeah.
It happened. To be honest with you, we start this project. It's actually in our cohort. We, in the past, I would say 2 or 3 years, we have one patient that in the allograft, like surveillance biopsies, we keep seeing those, inflammation, and then it's not like small capillary like in the interstitium. It's like big muscular arteries that with. Oh, Alex is showing you this. Yeah. See, my awesome trainee. Oh, but like, we did like consensus within our department, and then it's true, and it's not tangential. It's not because of it's a bolt that next door, because that's our actual first thought that it's actually just because, usually you see, bronchovascular bundle, then maybe it's bolt, but it's actually transmural and then truly, infiltrate into the tunica media and sometimes intima. And then so we start this research project. It's actually one of the patients, just like pretty much every single biopsies have this kind of changes, and we keep writing reports that the clinical significance unknown. So our group, we have 3 cardiothoracic pathology here. Then we say like, okay, what about let's look at it, and we identify other cases in our series. Some of them is actually in transbronchial biopsy for surveillance, and then some of them is class. It's very, very rare. Alex and I, we spend hours in my office to go through those. But I do believe this is a true phenomena, and as far as we can tell from our series, this patient never developed like high grade, clinically meaningful rejection. I ignored the A1, and then they're clinically doing well.
I presume they got worked up for AMR, because I remember Desley had a case like that way back when, that she called intimitis, and it was more than intimitis, actually arteritis, and patient actually had AMR.
The Sentinel case I mentioned, like that patient will be followed for like more than a year. Now DSA is always negative. The patient is doing well. There's no decrease of functions. Other cases, I mean, Alex, you know the clinical data better than me, but I remember we don't see any, because those patients will be followed for a while. I mean, none of them have the clinical evidence of AMR.
There was one that actually had pathologic AMR.
You know better than me, but
not at the same time. I forget the time frame between those. And then 2 patients had persistently elevated class 2 DSAs. I'm trying to figure out with our transplant center kind of like what the prevalence of those is. But I mean, we have 5 that we identified by biopsy. One patient had 3 or 4 different biopsies that had this in it. There's actually a new patient yesterday that we found. So I guess we have a 6th patient. And then of like 38 explants for retransplant, I think 4 or 5 we were able to find the lesions, but my abstract and all of my focus on the data has just been on the biopsies.
Yeah, I've seen this occasionally in biopsies. I mean, obviously, we don't often get vessels of that size in the biopsy. I mean, A, I don't know what it means. B, I tend to sort of flag it up as a potential mixed rejection because I don't quite know what else to call it. And usually the DSAs are negative. But I agree, it's an interesting lesion. I don't know what it means. So I think if we can gather a sufficient cohort of cases, well characterized, it'd be a fascinating study to do.
I agree. I think I have seen it too. I have seen it in biopsies because we only had like 2 or 3 retransplantations so far. I can certainly look there, but I think I have seen it, and if I have seen it in biopsies. Fantastic. So I would say whoever is interested and maybe has cases should contact GU and Alex.
Please.
May I just add something? You know that the clinician has described something like focal pulmonary hypertension. And I assume when I look at the explants that this might be a lesion which might be associated with this type of pulmonary hypertension because it has the internal proliferation and it has also the muscular, the smooth muscle cell proliferation. So it actually fits the criteria. The problem is that it's hard to catch because basically overall the lung pressure is not very much increased, but it's a known phenomenon in particular in children. So I assume that this might be a lesion associated simply with for some reason that the bronchus next to it it's obliterated probably in the context of bronchiolitis obliterans, and for some reason, or an organizing pneumonia or whatsoever, you have this kind of focal pulmonary hypertension, which leads then to some kind of focal inflammation, which we often see also next to tumors, isn't it? So the perfect vasculitis is seen in carcinomas or in squamous cell carcinomas next to them. So this might be, before we put out some kind of study which can't be rectified afterwards, just if you would like to check your pulmonary pressures, just to make sure that there is no increase.
That's a great thought.
Pulmonary pressure in these patients or at least focal ones.
We'll certainly check that. But some of our patients actually have this like fairly early. I'm not saying that they don't have pulmonary hypertension or obstructive, but like, for instance, the Sentinel patient that it didn't, develop, it developed like within the first 3 months of transplant. It's almost like quote and bolt, like they can immediately show up. So, and then we are not drawing any conclusion as of now, and that's why we're like call out for help, and then so we can have more data, both clinically and pathologically. So we can draw the conclusion. For instance,
so if it's within the I'm sorry to interrupt you, but if it's within the first 3 months after transplantation, don't you think that it might be associated with some kind of infection?
It could be, but
all
the BL was negative. All this patient, like that Sentinel case, we've been followed for more than a year, never developed any. So like the clinical course kind of like reveal itself. So, but as I say, this type of study, and then, for instance, when Alex and I, we start to review the slides, there are some like non-specific change that we exclude. purposefully keep this cohort like a really real, like, inflammation that cannot be explained by anything others. But I don't want to take much time, but this is, I want to share our preliminary data. That's hopefully we submit the abstract, and hopefully we will see this in the upcoming ICHOT meetings. But I really think that, there are more happening in the vessels of the heart, heart, actually lung, and then just D1 in lung transplant.
Right.
Fantastic. Thanks for bringing that up to you. And whoever would like to participate and discuss the project further, Gio put her and Alex's email in the chat. So please contact them. Very nice. Are there any other ideas for research projects? I know Francesca, I think you got something.
Yes, of course. I have to present a proposal by our group. In particular, Dr. Pezzuto wanted to explain to you about, talk about this project. Indeed, we have been considering involving pathologists in a collaborative study centered on neoplasms on the native lungs. Indeed, this project starts from some evidences of our group about a certain number of unexpected neoplasia in native lungs coming from lung transplant patients. And we presented these preliminary results during the last ISHLT Congress. Indeed, we found a significant number of our patients with particular types of mutations, occasionally even rare ones, identified by using next generation sequencing approach. Thus, it would be great if other groups, other pathologists would participate to this collection of cases, starting from an accurate examination of the native lungs, and so the identification of these unexpected neoplasia. And in particular, it would be also intriguing to examine, to ascertain whether a liquid biopsy could play a role in patients on the waiting list. Indeed, we have a lot of cases that arise at the lung transplantation with this high-grade dysplasia or foci of also adenocarcinoma, squamous cell carcinoma that are also involving the lymph nodes sometimes. So very difficult situation for the patients in their follow-up. Indeed, their survival and their follow-up is obviously very impacted by this neoplasm. So we would like to ask you if someone or some other groups want to participate, to collaborate, and in that case to contact us, in particular Dr. Pezzuto or Professor Calabrese, in order to take part, to obtain a greater study population, to investigate by next generation sequencing the gene mutation profile.
I think it'd be helpful if Fiorella could circulate with what the inclusion criteria are as an email round of suitable cases. So whilst I got a rough idea about the sort of cases you're thinking about in your presentation, and thank you for that. If it's a bit more sort of spelled out in a written communication, then we can all see if we've got cases to add into this. Because this is a recognized phenomenon, so it'd be interesting. And I think to get a handle on it, we do need to have a collaborative approach.
Any other comments? Thank you, Francesca. I guess the only comment I would have, I think it's a very important project, because what we see, they don't do a CT scan necessarily before the patient is transplanted. The last CT scan was maybe 2 years ago, 3 years ago, nothing new. And then all of a sudden you find this tumor in the explant. And so liquid biopsy, I think it's a fascinating question. And of course the outcome. Great. So if you have any interest, please contact Francesca, Frederica, Fiorella, and I really like Martin's idea to send out a kind of proposal where you include the inclusion criteria of these patients. In the end, we probably also should think about what is the percentage of these patients of all our explants. I mean, in the literature, it's about 2 to 3% of all the explants have an undiagnosed neoplasm. Can we confirm it? I think it would be a good a good chance to look into that.
Just want to make a quick comment. I think that's also this study will also like nicely link to our proposed guideline for the long sample for explain. So we will provide. So that's a perfect timing. Yeah.
Absolutely, yes. Okay, if there are no further questions, does anyone else has a proposal? All right, then let's move on. Discuss ideas for a virtual special issue in the IHLT Open. So you're probably all aware of, we do have the Journal for Heart and Lung Transplantation, and that journal now has a kickoff journal, which is the JHLT Open. This was just established. Dr. van Remdok is the editor-in-chief, and right now there is a call for any kind of publication or manuscripts which they would take for free until the end of the year, and after that it would be at a 50% discount for ISHLT members. And they had a call out you may have seen in the ISHLT Connect for any proposals for manuscripts that are actually driven by the professional communities and IDNs. And so if you have any proposal, maybe you have already something in mind, then please present it to us and we all can chime in. And I know, Greg, you had some ideas, and maybe it would be a good time now to bring up the idea.
So maybe I'll start with, we asked for what some examples are from other professional communities. And for example, I guess the surgery professional community wants to do something that's about what's new in each of the IDNs with particular regard to surgery. There was one about how we work in teams. I forget who was the putting that one together, but because we talked a lot about vascular disease and about the nomenclature for cardiac allograft vasculopathy, and then of course the phenotype and significance of the pulmonary allograft vasculopathy, for lack of a better term. I thought it would be interesting to talk about vascular disease, maybe from our professional community, and in both heart and lung, right? Because I think we've floated the idea of trying to come up with standardized nomenclature. I know, and Jerry, I think you sort of spearheaded this in a BAMF meeting, so that we can describe the different lesions of cardiac allograft vasculopathy, because it's still, I think in our latest classification document, still referred to as transplant atherosclerosis. And we know that, J.U., as you mentioned, that there's like sort of inflammatory lesions, there's proliferative lesions, there's overlap lesions, there's venous lesions, there's arterial lesions. At least in the heart, accelerated atherosclerosis is definitely there in the pediatric population. So it would be interesting to try to come up with some sort of review article that maybe also proposes some standard nomenclature for these lesions, and just goes through again, what the different lesions are, and then with that extending that into the lung as well. And even though the significance might be uncertain, if we can start describing these lesions, have names for the lesions, it makes it easier for us to study them, collaboratively and otherwise. And so I thought that maybe it would be something to talk about the, just like vasculopathy, in the heart and the lung, the phenotypes of vasculopathy. Just an idea, and I think it would tie in really nicely with any other collaborative research we do on that. And if we're thinking about putting any papers out about consensus nomenclature, I think a descriptive paper like this might be a good segue. Any thoughts?
I mean, I like the idea, Greg. I think it's a great idea. I think we probably got enough experience and maturity in the cardiac world to be able to do this. And I think, from the earlier discussions, we don't really have enough data or experience on the pulmonary one. So I'd keep within the time frame that's being proposed to get these things into the journal. I think the cardiac one is achievable. I don't think the pulmonary one would be, and that may be the focus of it. But it would highlight our activity as a community. So, yeah, I think that'd be a great idea. And it is something we've talked about in in other fora before.
Yeah, I think it's a good idea.
So I think, given that timeline, I don't think it's feasible for me to spearhead this project. I don't think I'm able to do it. I don't have the bandwidth. But if anybody would like to discuss, maybe we can figure out if somebody wants to champion this. Certainly, I think all of us have an interest in collaborating, for many of us.
Right. I mean, champion doesn't mean you write the whole manuscript. Champion just means bringing everyone together and deciding who is doing what, right? And then you just put it together.
That's sometimes harder.
The role of the
Hey, I want to make it more easy for people to champion it.
as Jerry knows, the role of the champion is to get everyone else to write it for you.
Herding cats.
It always was.
Well, I really like the idea. If
I'm happy to be involved, I'll put my hand up for that, but I'm not going to be a champion. I've got too many other ISHLT commitments on my plate at the moment, so I can't. But I'm more than happy to engage and be involved. So that's it.
it would be actually a good thing for our junior people here if someone would be interested, because you have all our bags.
I've never done anything like this before, but if I have guidance, I am definitely up for it.
You can have all our guidance.
All right.
Absolutely.
So what is the timeline though? Because you were saying
end of the year.
End of the year.
End of the year is for free. Otherwise, you have to go around with the hat and collect the money.
But only 50% of it.
Of what? I don't know what it is.
Yeah,
it's high. It's $2,000 or something like that, right?
Ooh.
Yeah, I think in fairness, if our trainee there is going to take this on, we should appoint one mentor to support, because having 8 of us in the room telling her what to do is not going to work.
Yeah, well, probably not.
No, believe me, it is not going to work. So I think, if you're happy to take it on, you should reach out to who you think you'd be comfortable working with and doing that.
Everything's frozen.
That's not a good sign to start that.
Okay.
How do you do that, Jerry?
It looks like things are moving again. I saw your video was frozen, but I could hear you.
Well, now here, just think about it. And,
we
we can
lost her.
talk about it also.
I think she just
offline.
logged on. She's going to log back.
Okay, she will log in.
Yeah.
Okay, are there any other proposals for the JHLT Open? Anything else? I mean, I guess we will be busy with one. That will keep us
I think I'd rather see the community do one well than split its resources and just end up in the weeds and stuff. I just don't think that's going to be necessarily the right way to go. So let's see if we can do this one time out. Then we'll see how we do it again in the future. That's my thought.
Is this an online? I don't know anything about this journal, but is this an online thing or pure online, or is this also going to be a?
It's a pure online open access journal. So I think that right now it's early enough that they don't have enough issues to be indexed in PubMed, but I think that's just impending, because it's brand new.
So it's only just started to come into reality. It's a pay to publish open access journal. And Elsevier, who obviously the publishing house under which this is embraced, are putting in all the support costs to start with to get it up and running, and for members offering these discounts for publication. And so it'll be good. We expect the impact factor to grow. Articles that aren't accepted for the main JHLT, if the authors wish it, will be offered the opportunity to be further reviewed by JHLT Open and so on. So we hope it will build to a reasonable impact factor within a short time from that.
Sounds good. Nahir, welcome back. So no, if you just want to maybe select a mentor and work with that person and then be all, or many of us. I mean, I would say whoever is interested in, please send an email to Nahir and voice your interest, and we'll take it from there.
Okay.
Does it sound okay,
I don't
Nahir?
want to point fingers because I don't know who's available. So if you have time and energy and desire, please send me an email and I will write it in the chat.
Very good. Cool. Thank you. All right. So our next and essentially last topic is ideas for future pathology-led ISHLT webinars. And before we get to that, I really would like to thank all the speakers and moderators and organizers from the last webinar. This was a great success. We were, I don't know how many people we were online, but afterward, it was already viewed by over 130 people through, I think it's YouTube, and the link was in ISHLT, and that is quite a large number, and it probably will go up. So I would say great success, and now it's time to come up with a new webinar. And so we were wondering if you may have an idea of what we could do, what you would like to see, what you would like us to discuss, maybe even with another work group.
And just to put on the table, we also discussed, that a while back we had something with sort of junior members or non-members. We were thinking junior faculty to present cases that then have sort of an expert discussant weigh in. I thought that was very successful, and it's a good way to, if we reach out to, maybe not necessarily fellows, but junior cardiac or pulmonary pathologists in transplantation who maybe are non-members even. It might encourage them to become members.
Yeah, either said, or if one of you has a case to what you think would be really good to present, that would be great. And then we would pair that with, like last time, with a discussant, so that we actually have a starting point for a discussion.
Right, it could just be cases. It doesn't have to be junior people.
Yeah.
Well, I just have the thoughts like, since, now here you and, we as a group are going to do that JHOT open, whatever that name calls, then maybe like a webinar that's along that line of vascular change. And so, since we're doing this already for the paper / manuscript, why not webinar, and also to gain more exposure and, discussion on this topic.
That's actually an excellent idea. And actually, that would be something we may be able to even do together with the pulmonary hypertension group to actually get some larger
When are the webinars?
audience. Pardon?
When is the next webinar being done?
Well, it's kind of up to us. You do like to have a few months of lead time so that that the speakers actually can prepare themselves or prepare the presentation. We had thought about next March, but it doesn't have to be that late. January would be working well too, probably. I think February is already quite busy from the ISHLT point for meetings.
I think we talked about the possibility too of doing one in March and one in January. So, I think if we wanted to do a case presentation thing in January, then in March, I really do like the idea of you could combine, the pre-transplant pulmonary vascular disease, morphology. I think there's still a lot to be said, about CTEPH and things like that, that would be very interesting. And then also with a discussion of the post-transplant vascular disease. That sounds great. And then it doesn't preclude us doing cases as well if people are still interested in that.
In regards to the vascular change, I know we had at least one proposal for a symposia. So we'll see. I guess I don't know when the symposia acceptance comes out, but we'll see what was taken and what was not, and we probably could take some of that also in the webinar.
Yes, indeed. I think that it is a good idea to look at the symposia that we hope that all of them will be taken for the Congress, but if it is not the case, it will be useful to see those that were not accepted. I had a proposal that came from Professor Calabrese. She couldn't take part to this town hall. And it was about the role of the autopsy for transplant surgeon and physicians. So if the autopsy still is an audit for transplant surgeon and physicians. So is it useful, the autopsy, when unfortunately the patients doesn't go well, but the results of our autopsy is still useful for them or not? She was thinking about this type of topic, a sort of debate among, I think, between the pathologists and the physicians, surgeons to look at this aspect. What do you think about?
So I think actually that's an excellent idea. And I remember a few years ago, I think, Jerry, you had organized one of the symposia and said, I think together with Dylan Miller, one of the symposias about that at the ISHLT meeting. And it seemed very well received also from the clinical point of view. There were quite a few clinicians in there. I think the title was Bring Out Your Dead or something along those lines.
Yeah, well, if programs are anything like ours, we've gone from virtually every heart transplant patient getting an autopsy to virtually none now. So it's quite a change in the clinical practice. Not through our fault, but they just don't ask anymore. The patients are dying remotely or whatever. But so I don't know what other people's experience are, but that's our current.
Well, I mean, Greg, we did that, the heart transplant autopsy, I cannot say that Japanese name, but the chit chat session in the last ICHOT, but at that point, and Carmela, you were also on the panel, and then actually we got great feedbacks, and it's actually highlight like the clinical teams are looking for things that are totally different than what we pathologists want to look at. So for instance, I think that's a great that's a great idea. I watch you. We are actually reviewing all the heart transplant autopsies and lung transplant autopsy. We did see some decline. But just to give you a number, that's we got 89 or 90. Gosh, I don't have that Excel file. Autopsy in the past 40 years, and then we saw decline after 2010, early 2000. But it's kind of like maintained. So each year we got about 10. Heart transplant death autopsy. So, Jerry, I agree. It's kind of like how practice shifts, what's the clinical teams think about, and then, I think have a multidisciplinary discussions will certainly help. In our series, we did find findings that the clinical team just have absolutely no idea prior to the death, either allograft failure or most commonly that's they miss like the non-allograft related death.
I've always thought an interesting project would be the historical nature of primary graft failure, because now virtually everybody who gets primary graft failure sits and rots on ECMO for a long time, and then all we see is the secondary effects of long-term ECMO. But I've got cases going back 20, 25 years where there was no support, and what the hell was primary graft failure? And there are now so many more different techniques and technologies we can use to interrogate the tissues. That'd be a very interesting cohort to look at.
Yeah, that's a great idea. And also we also see the shift, like for instance, like, the cause of the before and after, like we shift from cyclosporine to tacrolimus, like, we saw, early on, we actually have like, renal failure, like the patient died of renal failure because of the cyclosporine toxicity and so forth and so on. So certainly the cause of death. And then also like the patient's trend, like demographic has changed in the past 40 years.
We're seeing far more dilated cardiomyopathies, less ischemic heart disease, and more transplants on VADs. So I think that's echoed around the world. So it is a changing cohort of recipients as well.
Wonderful. Any other discussion points, ideas for webinars?
Not for webinars, but another idea.
Right. Okay. Just a second. Let's finish the webinars because you know, even though it's January or March, time is flying. So what I would suggest is, if you want to be involved in the development of the webinar, and I think whoever brought up a proposal would be excellent starting point for that, but everyone else too, please send us, Greg and myself, an email, and we will start to coordinate that. And also, if you have maybe a case which you think should be or could be presented, please let us know. All right.
I also think Francesca's idea that if there are symposia proposals that don't get accepted into the Prague meeting, to look critically at those to say, do they form the basis of a webinar? Because somebody's put together an idea for something that they thought was important and worthy, and if that work has been done and that idea is good enough, then it is the substrate for a webinar. But I think that's down to maybe you and Greg to review independently and then sort of reach out to other people.
Yeah, I'll just comment on that because I think the Heart IDN has also have the same ideas that for our IDN webinars we could use recycle some proposals. I think the timeline is such that we don't really get that we don't get the final word on what the sort of rejected symposium proposals are until late in the game, and so I don't think, unless Juliet, you can speak to when we will find out what accepted and rejected symposium proposals will be released.
But we can do the webinars after the meeting, not before the meeting.
Right.
So I don't think
we are trying
should
to
lose
plan
focus.
some before.
Yeah.
But also might be a good opportunity as sort of a fine-tune something for the submission for the following year too.
Right.
Yeah,
I think that's what happened in the Heart IDN. We sort of talked about using some of these as webinars, and then by the time we got it, we sort of shifted to like, can we refine this for next year?
Submitters
I think that's worth it.
Yeah, submitters will be notified early October 9th. So there's no way we can speed it up, but that's the earliest.
Okay, well, we'll see. We always can take that for a later webinar for after the meeting. Yeah, very
I don't
good.
know what's been going on more recently, but it's certainly in the last 10 years, so they'd often sort of scavenge. At least when I was on program committees, they would usually scavenge and take parts of different proposals. So it was quite uncommon that you'd have the entire proposal that was originally submitted that would go through, and they would piece them together with other proposals and things like that. So there's still good room there's lots of room to, even if only partial, 2/3 of a proposal is not accepted, then we can still work with that.
Yeah, I think there's slightly less of that horse trading that goes on now, Jerry, because so many more of these proposals come through the interdisciplinary networks and already sort of try and reach out across communities to give them broader appeal already. So there's less of that sort of bunkered things from each professional community that goes in now, much more breadth to them. So less of that goes on in program committee than it did when you and I did it.
I think
All right.
I think another project that would be interesting is to discuss the interpathologist consistency between diagnosis and rejection, and because it comes up all the time, and I think it would be a good format or something that would be good to discuss before we propose that an update to the guidelines, because I think that's part of the reason you have guidelines, is so that it's consistent, and there's many more studies being done across centers. And so I think for us to address it might be good as a group, rather than, because I don't know the rest of you, but oftentimes I hear that there's poor interpathologist consistency in grading, and I don't know that that's really true.
I would agree with you. I don't think it's as bad as it used to be. I think pathologists have got better at this. Our biggest problem is that we have over 400 transplant centers registered with ISHLT across the world in many countries, and we have 40 pathologists representing 25 centers. And I think those of us who do a lot of this and are engaged as ISHLT are probably all pretty good at what we do and consistent. It's what the rest of them are doing that's the problem. And I think we need to be doing something along these lines in order to get better engagement of pathologists in the society.
Catherine, I think that's a great idea. I know you and I and Greg were involved in a multi-institutional study where we did just that. We sat around and looked at different biopsies and we talked about where the challenges were and where we differed. And I think it would make for a great broader discussion, especially as we approach looking at updating the guidelines, because it really does highlight the areas where more description is potentially needed for better agreement.
Yeah.
And it would also be the foundation for, you know, educational programs for people in the community. If it's true that people that do this all the time and that's their interest, that there's better agreement, then what are the areas where we can help educate others or, you know, address any issues?
All right. Thank you, Catherine. And so I would say same thing, Catherine, that probably goes under the projects, right? And if you want to initiate something, that would be good. So I know, Martin, you wanted to say something.
So yeah, this whole idea about consistency segues very neatly into what I wanted to discuss. And that is about, you know, a lot of the other areas and disciplines have their academies and master classes and things like that. And at the moment, the pathologists who attend are the same pathologists who we have sitting here and don't do this. But I was talking to some people in the Far East, and, you know, us organizing a teaching seminar for pathology within the Far East, we have no members from the Far East or Australasia. So the Pacific Rim, we have no members. I mean, Australia is a big transplant area, but none of their pathologists are members. So this would be a sort of outreach, and certainly the people in Singapore were talking about allowing us to sort of slip into one of their meetings and do that, and we get some support for that. There may be support within ISHLT for that. I certainly think that looking further ahead to 2027, to be able to put on something like that as a pathology community based around the Sydney meeting would be extremely useful. I'm not so sure I can see the value so much in the American meeting. American pathologists have enough American meetings to go to and aren't going to drop into a transplant meeting necessarily, unless we can make it a standalone session. And we'd have to talk, that would have to go through the board to be able to do that within the setting of the meetings. But I just think, again, in terms of our outreach as pathologists and getting more engagement, that's probably what we need to be thinking about. So I'm not going to say it's going to be cost neutral to everybody, but it's could be an opportunity to go somewhere.
I would love to do that. And actually I have some colleague, like I originate from Taiwan. Actually, I just have colleague, you know, reach out to me that their one and only cardiac pathologist is retiring and no one can read heart biopsy and lung transplant anymore. So I think that's a real, you know, that's a really a real opportunities that we can benefit and also attract more members to our society.
Yeah, so we need to, I think we need to have a sort of standardized format of presentation. We need to have a number of people who can deliver those presentations. I think also one of the powerful things is to be able to do some real-time review of cases that they've found difficult and looked at. You go out there, you're going to look at them blind as a panel of experts and say how you would deal with them. So they bring you your difficult cases. So they get that bit of learning as well as just the standard lecture type delivery. But we can discuss how that goes. But I thought this might be a good time just to raise that with this group to see what people thought about that. I don't need an answer tonight. It's just putting it out there.
Just as a matter of fact, we have a member from Australia, which included in my symposium proposal, as well as one from Azerbaijan, which are also included, just to have diversity from all sides. So what we don't have is from Russia. And this is a pity, because I know colleagues from St. Petersburg who are performing still biopsies, and these are 600 per year. So they are outnumbering us in any single form. So basically, I have been invited for the Russian Society of Pathology meeting, and it's not only St. Petersburg, it's also Novosibirsk. You wouldn't imagine it, but they're also performing about 500 biopsies per year for the heart. Not so much for the lung, but for the heart. So it would be worthwhile looking in this area, also in China, in Russia, in Taiwan, in India. In India, I know there are really huge transplant centers, and I'm not sure that we have any member from there. But
And also
I'm aware
Japan,
that,
yeah.
and also Japan, yes.
I don't think we'd support going to China.
Hey, Martin, that's an excellent proposal. I really appreciate you brought that up. And it's actually good timing now to start preparing for that, even if it's 2027. How to
But I think
attract the local people and so on.
Certainly there may be an opportunity in Singapore prior to that. And I think, as Katerina says, there may be opportunities, particularly in parts of Eastern Europe and the Indian subcontinent, where that might also be possible. And there are other links with their transplant societies that the society as a whole is developing. So there may be ways in which we can get that introduced.
All right, thank you so much, Martin, for that introduction of the concept. So with that, it's after 3 o'clock. Thanks everyone for actively participating. That was great. And hopefully there will be some email communication in the next couple of days and weeks about all the projects and webinars we had discussed. And otherwise, have a nice summer.
Great.
Bye.
Thank you, Anya.
See you.
Thank you. Bye.
Thank you. Bye.